Congenital heart disease is one of the most leading causes of birth defects in Kenya. When diagnosed and treated early, the life-changing transformation for a child stays with them for life.
Nimekuja hapa sababu ya matibabu ya mtoto wangu Alvin ambaye alipimwa akaonekana ana tundu kwa roho. So ilikuwa ni wakati wa kuzaliwa, amekuwa akikaa hivyo kipewa appointments.
On this morning, we meet up with John Ndiema, visibly anxious just like any parent would be when their child is about to be handed over to a team of doctors for a procedure.
Unajua hospitali hakuna mtu ananga wasiwasi, ama sijui kama ni mimi, mpaka kila mtu anakuwa na wasiwasi, lakini vile amenielezea sasa wasiwasi yangu imepungua.
The uncertainty in Ndiema's mind is whether his son, otherwise healthy looking, will come back from the operating room without the need of any other surgeries and long-term medication.
Kuna mashini itaingizwa ambayo ina kamera yake. Halafu ikifika hapo watafili upande hii na huko. Isipoingiana watatoa. Nipe muda akuja afanyiwe surgery sasa.
He had previously gone to various hospitals in search of treatment to seal the hole in his son's heart, but all of them required an extra amount of money in addition to what his NHIF cover could afford. But today, this procedure here will be fully paid for by the national insurer. And with that, his son was in the hands of doctors for the procedure estimated to take about 30 minutes. Today we are here at Medihill Cardiac Catheterization Unit, and we'll witness how a hole in the heart is closed without necessarily doing open heart surgery. The surgeon or the doctors will go through what we call the femoral vein through the thigh and access the heart and be able to close the hole in the heart. So because this is guided by radiology, x-rays, we need to be well protected, and these are lead gowns. They are quite heavy, but they protect against radiation. So this one covers the thyroid, which is sensitive to radiation. And then obviously this covers the vital organs. So let's go in and see how this hole is closed without opening up the heart. This is one of many interventional cardiology procedures that Dr. Vijay Sin Patil does daily.
God has made so perfectly everything. So each vessel finally will land up into the heart. So the big vessels usually are the femoral. In groin, we have the femoral artery and femoral vein. Those are the big vessels. And in kids specifically, it's better to go from the maximum bigger vessels. And those are the accessible easily. They are straight with the heart. From here, we puncture and we pass the wire. It will go through the one bigger, another vessel, it's called IVC, and through that it will communicate it with the right atrium, one of the chamber of the heart. So they are in the line. So we can able to pass bigger sheath through this, and in that sheath means is a big tube. And in that tube we are putting this device in a folded manner, and they are connected to the outside, and through that tube we are passing this device till the heart, and we are crossing that defect, and we are placing one part of the device on one side and other part of device on opposite side of the hole.
Prior to the procedure, the doctors, the interventional cardiologist, cardiac anesthesiologist, and the echocardiographer scan the heart on ultrasound to confirm the location and size of the hole.
It will come, this is right atrium, and the defect is on this side. We'll cross through this. We're keeping catheter here, and then one disc will open here, one disc will be open here.
This gives them a visual bearing of the site of operation.
In adult, for the device closure, best access always will be the femoral. Radial, very few, because these vessels are very small. Radial is good for the coronary arteries. Whenever we are doing the angiography, angioplasty, 99% now we are shifted on the radial axis.
In case of a heart attack, therefore, and there is need to open up a blocked artery to the heart's muscles, the radial artery in your arm is used to access the heart. But since this is a congenital birth defect, the big artery at the groin works best.
In Kenya, so many, in a 1 month I am seeing so many patients, more than 40-50 interventions we have did. And if that is the ratio, definitely as compared to the any Western world, in Kenya there is need of more intervention cardiologists, and we are ready to give the training in most of the procedures. Even yesterday I have given one training for the angioplasty, one of my colleague. So we can actually give good training, and we can develop one good intervention cardiology lobby, so that what is need in Kenya, so many people are having structural heart disease, coronary artery disease, DVT, pulmonary embolism. Those are the bigger problem we are facing in Kenya, and for that, for looking at the patient population, definitely we need more intervention cardiologists.
Once the doctors have accessed the arteries and the procedure starts, X-ray is used to determine the position of the guide wires along the arteries, and the views can be dramatic as the beating heart is accessed. Dr. Patil explains that interventional cardiology procedures such as the one he's doing today can be challenging in children because their blood vessels are still small compared to those of adults. In other instances, the hole is too big to be closed this way and may require open heart surgery, which is riskier.
They are very difficult to manage. They are a lot of family pressure will be there. There are always issue with anesthesia, vascular access in pediatric cases, especially less than 5 years or less than 10 years. We usually do the device closure for any hole in the hearts, like if it is hole in between the atrial septum. We have 4 chambers in the heart, and if there is hole between upper chambers, those are called left atrium and right atrium, and in that chamber there is a barrier. And if there is congenitally from birth, if there is hole, that's called atrial septal defect. And if it is that happen in the lower chambers, left ventricle and right ventricle, it's called VSD. And some defects are there between pulmonary artery and aorta, that's called PDA. So these are the holes which may present since birth. If we are not treated in the time, over a period the lung pressures will go high, and once lung pressure goes high, we can't even operate, we can't do the device closure. So before developing pulmonary hypertension, we need to treat these conditions, and if we do treat them as early as possible, the risk of complication, if I do the AST device closure in adult, already chambers are there enlarged, the risk of arrhythmias, those we are not going to reduce. But if in children, if you treat in early, so they won't develop any arrhythmias, no chamber dilatations, and they can live normally as a normal child.
Patience and precision finally lead to the most critical part of the procedure, introducing the device to seal the hole.
20 mm size device, as there is AST of 14 to 15 mm size, which is having 2 discs. One is on left side, one is on right side. So it will block. The ASD will be sitting inside this, and both sides this device will be. So this is the AST device. We are passing through the sheath. I am going to deploy this left sided disc by pulling the sheath down. So this has.
The same happens on the right side of the heart where the hole is. With that, the hole is sealed successfully. But this has to be confirmed immediately by the echocardiographer, who has all along been observing the progress of the procedure. Once confirmed to be in the right place, the device is detached from the guiding wire by simply unscrewing it. It's been slightly over an hour since this procedure to seal the hole in Alvin's heart started. The device has been successfully fixed without the need for open heart surgery, and Alvin, for the rest of his life, will live like any other child. Dr. Patil briefs and explains to Ndiema the outcome of the procedure and what is expected of him in the next 24 hours, time which is absolutely critical for Alvin.
It was very difficult femoral access, and this is called femoral vein, and which is communicating to the iliac veins, and it is draining up into the IVC or inferior vena cava. And through that we passed one wire. So this wire we cross, there is the defect. This we need to see on echo, and we need to assess clinically, anatomically. We have passed first wire, and over that wire we are passing small tube, and over that tube we have passed this one of tough wire, and on that hard wire we have passed this bigger sheath. This is called sheath. It is a big tube. It was 10 French tube. We have placed, there is a hole, and across that it has gone. And now once this tube is ready, we have assessed already how much size was AST. It was around 14 to 15 mm. So 2 to 3 or 4 size extra we need to take so that it will fit properly. And that's why we choose 20 mm device. And it's as I told you, it's folded device. We have folded in the tube. It's a nitinol mesh. So if we keep open, it will behave like this, and if we fold them, it will become straight. Okay, so this is connected to this connector here. It's called delivery cable, and through that we have passed this device. After passing this, we have pulling this sheath back and releasing one disc. This is LA disc, left atrial disc, we have released here. And then once that disc is properly snug across that hole, we have pulled back the sheath. Here the defect, and this right sided disc we have placed. So both the discs we have placed there. This device now looks like this. This is LA disc, this is RA disc, and now we are checking it has properly fit there or not. Here is a hole, and this disc is on one side, this disc is on side, and it is connected to cable. So if it is not fitting, we can remove any time at this moment. But it was fitting properly. We have pulling vigorously, still it is not displacing.
The father's joy was palpable.
Don't worry, you will be fine. Okay?
Yeah.
Dr. Masi Korir for KTN News
angle
Health
we are
Watch.
assessing.